This Telangana, who's going to showcase their young guns talent. And this is a webinar I think we have gotten used to waiting for. It shows you the depth of the knowledge that we have, even in the peripheries, even all throughout the country. The young guns, they speak with confidence, they speak with great scientific depth, with beautiful images and a wonderful follow-up. So their cases are unique and it provides an opportunity for us to learn, to seek new knowledge. It's a wonderful way of updating yourself, getting to know unique things, rarer anomalies, and a wonderful interaction that follows. Really looking forward to it. I would request Dr. Chinmay Rath to take it forward from here. Introduce the panel and take it forward. Thank you very much.
Thank you. Thank you very much, Mohit sir. Meerandariki namaskaram. SFN Telangana welcomes all of you to this evening. And we are really grateful to the Central SFM for giving us this opportunity to present our young guns in front of the whole country, because it's a younger society, but it's a younger society in terms of its inception. But now that we are discovering more and more young talent, we are feeling younger and younger. And at the outset, I must thank Dr. Alok Varshney for this beautiful concept and the amount of effort that he has taken in, helping us put this program together. I'm sure all our young guns have, learned a lot, because he's actually looked through their presentations and given them inputs in how to present. So with that note of thanks, it's always good to see youngsters come up and present things, because we have all gone through the same route, and with mentors like Dr. Ashok Khurana, we took our first steps and learned things at that stage, and it's nice to pass on the baton to others. So without much ado, today we have 5 young guns from SFM Telangana, and they will be presenting a niche topic on which they have a representative case, and they have learned a bit of theory to share with all of us. So I don't know if Dr. will say something, or shall we just move on to the first presenter?
I think we'll move on. Yeah.
Okay, so the first presenter for this evening is Dr. Shushma Meda from Miryalgoda. Dr. Shushma, can you start sharing your presentation? So Dr. Shushma is practicing in a place called Miryalgoda that comes under the Nalgonda district, and that is about, if you have to go on road, it's about 1.5 to 2 hours from Hyderabad. And she has trained herself in fetal medicine in Bangalore under Dr. Adinarayan Makam. And now she does full-fledged fetal medicine practice in Miryalgoda. So it's a very great service that she's providing to people there in Nalgonda, and a very active member of the Society of Fetal Medicine, a part of our state executive committee. Dr. Shushma will be presenting on Chondrodysplasia Punctata. So Dr. Shushma, the stage is all yours.
Is my screen visible, ma'am?
Yes, it's visible. You're audible. Start.
A very good evening, everyone. Today, my topic is Chondrodysplasia punctata, and I'll be going through checklist for a flat face. Due to paucity of time, I'll rush through the slides. A primey came at 6 months of pregnancy. Dating scan was done, but missed her NT scan. And on ultrasound, in mid-sagittal section of face, we could see flat face. And she came in the year 2022 at 21 weeks of gestation. On a clip, in coronal section in nose chin view, we can see that the nostrils are buried due to short columella. And because it is a flat face, we looked for premature calcification of epiphysis, which is not there. And tarsal bones are normal, and there is no coccygeal ossification. So on 3D scan, rather than frontal approach, on lateral approach, it is seen much better with increased frontonasal angle and very short columella and protruding lips. So patient was advised that it could be isolated flat faces, or it could be a mild variation of Chondrodysplasia punctata, which could be because of SLE. And so they opted for ANA profile testing and it came out to be normal, and it could be genetic cause. So they opted for whole exome sequencing and it came out to be normal. So the cause is attributed to hyperemesis, which was limited to first trimester in this pregnancy. And she continued the pregnancy and delivered a healthy female child, except for the flat face. Then she came back in her second pregnancy. And this was in the year 2023. And yeah, we could see that frontonasal angle is increased compared to the normal control image here. Normal frontonasal angle is less than 140 degrees. In this image, it is 158. And in axial section at the level of the orbits, normal protruding nose that has to be seen here in a normal image is flattened. Axial section at the level of maxillae, instead of the normal U shape, it is flattened and rectangular in appearance. So now that the flat face is confirmed, we are going to do a checklist of what all to be imaged on ultrasound. So we should look for premature calcification of long bones, epiphysis of long bones. Here in this case, femoral epiphysis is proximal femoral epiphysis is prematurely calcified. There were no other premature epiphyseal ossification in other long bones. So the first thing to look for is epiphysis of long bones. Then we moved on to look for talar bones. Here in this image, there are 3 tarsal bones that were looked. Normally at about 19 weeks, there should only be 1 tarsal bone, which is calcaneum, and the second one, talus, appears at about 22 to 24 weeks, and the third one, cuboid, appears at 9th month of pregnancy. So here by 19 weeks, we could see all the 3 tarsal bones. Then we move on to looking at carpal bones. Here, this is radius and ulna, and these are metacarpal bones, but there are no carpal bone ossification. Then we move on to look for coccyx. So in the spine, when we look at the sacral bones and the lumbar bones, here the first one which makes the angle, it is lumbosacral point and it is S1. And the next bone is S2, next bone is S3, and next bone is S4. So S1 should appear at 15, S2 at 17, S3 at 19. So by 19 weeks, we should look at till S3 only. But here S4 is also seen, and also there is an additional bone here, which is instead of directing posteriorly, it is jetting anteriorly, and this is coccyx. This is a normal image for comparison. And this is the clip showing ossification of coccyx, premature ossification of coccyx. So the next thing that we look at as we move on from sacrum and lumbar, the anterior ossification centers of sacral and lumbar vertebra are normal, but there is cleft in the lower thoracic vertebral bodies. What we see, the cleft in the sagittal section is coronal cleft. Here at the level of kidneys, the vertebral body appears normal, but as we move on to the thorax, at the level of the heart, we can see a cleft, both sagittal and coronal cleft. Coronal cleft can be seen in sagittal section, whereas sagittal cleft can be seen in coronal section. I'm sorry, am I audible, ma'am?
Yes, we can hear you. Yeah. Move to the next slide. Just discard this and move to the next slide. Yeah.
So this is a coronal section showing in the lower thoracic vertebra, we can see sagittal clefts. We should also see for cataracts, which can get calcified. And we should also look for tracheal ossification, which is seen in this fetus. This is another clip showing tracheal ossification. Then we should look at the length of the long bones. Here in this case, there is no rhizomelia. Femur length and tibial length is normal to rule out rhizomelic chondrodysplasia punctata, and also to rule out tibio-metacarpal type of chondrodysplasia punctata. Then we are looking at phalanges to rule out brachytelephalangy type of chondrodysplasia punctata. Here proximal and middle phalanges appear normal, but the distal phalanges appear stippled. So we were suspecting brachytelephalangy in this case. So apart from this, we need to take a detailed history of hyperemesis, consanguinity, and drug intake of warfarin, and history of SLE. So now in this patient, after going through the detailed 2D scan, we have taken a 3D picture. And this is the clip showing extreme flattening and protrusion of the lower lips. So we have done extensive counseling in view of extensive calcification seen in this fetus. We were especially horrified looking at tracheal calcification. But these patients now in this pregnancy refused any further testing. They did not go for genetic testing as well, but they wanted to continue the pregnancy. So they came for follow-up at 26 weeks, and at 26 weeks, we could see clearly the clefts in the vertebral bodies. They came for follow-up at 30 weeks. And this is in 2023. And she delivered a male child. I'm not sure I can say a healthy male child because it is with CDP. And they came back to me after 1.5 years. And this is the child. This is on side view and this is on front view. And this is his elder sister, the first child only with the flat face. This is in straight view, oblique view, and in side view. And these are their parents who have normal noses. And these are the duo. And as we are suspecting brachytelephalangy, we confirmed it. The child, the baby male child is having brachytelephalangy. But any guesses why she came again? She came for her third pregnancy. And this is in the year 2025, March. And she was 9 weeks pregnant. And again at 17 weeks, we could see that there is flat face. And at 21 weeks, frontonasal angle is 146. Normal is 140. And this is the baby delivered yesterday. Now, this baby is not having very much flat face. So flat face improved with gestational age. So now to the duo, the child, girl child delivered, and they became a trio. So we'll quickly go through this article by Dr. Adinarayana Makam and Dr. Ashwini and Dr. Dhruva Rajgopal. How to approach a fetal flat face on ultrasound. Take a detailed maternal medical history and do a focused scan for CDP, followed by karyotype with chromosomal and microarray. If aneuploidy is detected, manage accordingly. And on ultrasound, if there are no CDP features and if karyotype is normal, then it could be isolated flat faces or it could be mild form of CDP. So postnatal follow-up is warranted, which is our first case, the female child, where it was isolated flat faces. But if CDP features are present, then it is altogether a different scenario. We should look for rhizomelia on ultrasound. And if rhizomelia is there, then we should look for plasminogen synthesis pathway, rhizomelic type of CDP, the genes involved, but it has severe, it's a severe form with poor prognosis. If there is no rhizomelia, we should look for short distal phalanges. And if short distal phalanges are there without rhizomelia, then it could be vitamin K embryopathy, which is brachytelephalangic type of chondrodysplasia punctata, which is X-linked recessive, and it only has mild morbidity and relatively good prognosis of all types of CDP. And if there are no short distal phalanges, then it could involve peroxisomal pathway, which is autosomal recessive, and it also has poor prognosis. And it could also involve cholesterol synthesis pathway, and it is X-linked dominant, that is Conradi-Hunerman syndrome, which also has poor prognosis. And sometimes when no mutation is identified in CDP tibio metacarpal type, even this one also it is autosomal dominant and also has poor prognosis. So out of all the types of CDP, vitamin K embryopathy with brachytelephalangy has mild morbidity and better prognosis. Rest all, they can be either autosomal recessive involving peroxisomal pathway or X-linked dominant Conradi-Hunerman involving cholesterol synthesis pathway, or autosomal dominant in tibio metacarpal type. All of them have poor prognosis. Take home message: not all CDPs require termination, and flat faces can become better by birth. And whenever you get a chance to present, don't miss. And no webinar is complete without thanking those who helped me contribute. I would like to thank Dr. Chinmay ma'am, not only for giving me this opportunity, but also giving us timelines and making us do it on time. And Dr. Alok sir for his mentorship, and SFM Karnataka President, Dr. Adi sir, my guru, Dr. Manikandan sir, Dr. Mohit Shah, and Dr. Ashok Kurana sir for bringing all the gurus together. And also my friends. Thank you.
Thank you very much, Sushma. I think beautiful presentation. You're getting a lot of accolades there, well deserved. And I think I will take home your message and impart to everyone that whenever you get a chance to present, please present. And that's a very inspiring thought for all other youngsters. So wonderful presentation. Stay online because we will be having a session of question answers. Already there are lots of questions that have piled up. We will discuss this at the end of all the presentations. So with that, we move to our next presenter, that is Dr. Aditi Shastri. So Dr. Aditi Shastri is, she actually trained with me almost, I think, 12 years back, Aditi, if I'm not wrong. So now she is a co-consultant in our unit. And she was arguing with me that she's not so young after all, but we always feel they are young. And she has a distinguished career in medicine, having done her MBBS from Pune and DNB in SRHC, and then her fellowship, and received all the FMF accreditations. So Dr. Aditi is going to present an interesting case on congenital hydronephrosis. So Aditi, the stage is all yours.
Thank you, ma'am. And I'll start with all the thanking when Dr. Sushma has ended with all the thanking. Thank you so much to all the seniors and to SFM for giving us this opportunity today. So as ma'am said, my case today will be congenital hydronephrosis with a special emphasis on LUTO, or the lower urinary tract obstruction. A quick brief on what most of us know, but the incidence is around 1 to 5% of all pregnancies, and it is male predominance of 2:1 ratio. It is bilateral only in about 20 to 30% of our cases, and these are the ones that we are really worried about, because the unilateral ones, and usually the mild ones, are the ones which may even resolve in up to 80% of the times. The risk factors are maternal diabetes, and let's not forget the genetic syndromes, which seem to be the villains in many, many things nowadays. We know the primary and the secondary causes, which is like obstructions at the different levels. And the secondary causes are when they are associated with other abnormalities. This is a lovely cartoon which I found off the net, which shows us the pathophysiology of hydronephrosis, where basically there is a block somewhere along the path, and then there is a back pressure change, therefore eventually almost strangulating our kidneys and then thinning out the cortex. And what we need to look at particularly in our scans is what all we can see too much of, and then decide where exactly the block is, and then so on and so forth we prognosticate. A quick word on the classification. There are many, many classifications if we look back in time. But finally, in 2014, 8 scientific societies came together, put their heads together, and made the UTD classification, which is the go-to classification now for any kidney problems. And I'm sure we all know this, where in the antenatal part, we have either the UTD A1, which is going to go to a UTD P1 later, which stays low risk. And then you have the antenatal A2 to 3 group, which eventually could either go into the intermediate P2 postnatally, or a high risk P3 postnatally. Now, I want to just show you all quickly some great work that is being done lately with regards to different kinds of obstructive uropathies in the CACUT group. But universally, everyone has told us that it's the UTD classification that we need to look at, and the oligo or anhydamnios before 20 weeks of gestation, which is what will actually count in prognosticating and handling the cases. Some of them have also proposed measuring bladder volume in cases of luto, and as well as looking at the urinary biochemistry on the vesicocentesis. So these are two very nice papers, and recently we've got the Delphi consensus as well on luto, and the highlights are that pick it up, suspect it in the first trimester when you have the longitudinal bladder diameter more than 7 millimeters, and then you confirm it later looking at the bilateral hydronephrosis, the dilated posterior urethra, and of course the oligohydramnios. Always recommend genetic testing. And unfavorable signs for you to counsel would be if the kidneys are looking really bad, like there are cysts or hypoechogenicity, if there is severe oligohydramnios. They have suggested at least one vesicocentesis and given us the renal biochemistry on which we can prognosticate. And they have said that we can consider the interventions like the vesicoamniotic shunts or even fetal cystoscopy nowadays. Yes, you heard that right, fetal cystoscopy nowadays, when the gestational age is beyond 16 weeks and if there is oligohydramnios. But remember that the intervention aims to restore amniotic fluid and therefore give a better lung maturity to these babies more than anything else. And the success rates reported in literature are not more than 50%, even in the best of hands. So they have again strongly suggested expectant management as well if you have a good postnatal setup. Coming to my case, we had a 34-year-old female who had a precious pregnancy in the sense that her previous pregnancy was a right tubal ectopic managed medically, and this was an IVF conception with her own gametes, non-consanguineously married. And they were referred to us in view of a hypoplastic nasal bone and a UTD A23 diagnosed outside. NIPT was already done for them, and they were also a type 2 diabetic on insulin. So she came to us at 16 weeks, 5 days for her early TIFA, where we confirmed the UTD A23, where there was bilateral hydronephrosis with a dilated bladder. And that's when we started talking to them of the suspicion of the luto. And we also picked up that along with the hypoplastic nasal bone, there was also a unilateral club foot, which was not earlier reported. So this is how the kidneys looked at that stage. What I would like to bring out is that though we did suspect the luto, the kidneys did not look very angry and very, very dilated at this stage, as in the cortex was still, corticomedullary differentiation was still seen. However, in the presence of the multiple abnormalities, we suggested an amniocentesis, and I would like to bring out that this was a very committed couple. They hardly took 2 minutes to make that decision, and they came back and said, yes, we want to go ahead with it, and an amniocentesis was done, and the sample was sent for an exome plus, which basically covers the microarray and the common genes. Then we reviewed them at the TIFA scan. Here, if you can see, the bladder now looks more prominent. You can see the keyhole sign coming in. The kidneys also are now really showing up the dilatation. Our report had come back in where the exome plus and the QFPCR was reported as normal. Once again, we counseled them, and the patients opted now for a vesicocentesis, and they had decided that they would think of getting an shunt if the vesicocentesis report came as favorable. I would like to bring out that the amniotic fluid, which you can see here in the pictures here, was still within a low normal range for gestation. I have two quick videos here. The one on the left showing how the baby looked, and you can see the bladder, you can see the club foot there in one of the pictures. And on the right, if you focus, you can see us going ahead and doing that vesicocentesis. We are planning our approach, and you're now seeing the needle coming in from the right, and you will see it entering the urinary bladder. You can see the tip now in the cavity, and then finally into the bladder. We recovered about 6 ml of urine that day, and we sent it for a biochemistry. And I would like you to focus on two of these values. One is the microglobulin, beta 2 microglobulin, and then the urinary sodium. And I've put the reference values on the right for you all to compare. So as you can see, the values were neither here nor there, as in neither were they saying poor prognosis, but it wasn't saying very good prognosis either. And once again, once we counsel them, and the amniotic fluid continued to remain within the normal range, the bladder was seen to be emptying. Even though partially it was seen to be emptying, we counseled them, and the couple actually opted out of a vesicoamniotic shunting and decided that they would rather go ahead with expectant management with a amniotic fluid and Doppler surveillance, which is what we continued. The baby, the lady came to us in preterm labor at 36 weeks, at which point we delivered her. And the baby cried immediately after birth. 2.6 kg baby was shifted to nursery. The significant features were that there was continuous dribbling of urine, which was present. And the initial serum creatinine was 0.83 milligrams per deciliter, which we were very happy with because it came within the better prognosis, which is less than 8.5. We also, of course, confirmed the CTEV, and there was a dorsal dermal sinus seen. Now, there was this is a small paper by the European Society of Pediatric Urology, which said that when the level of the creatinine is above 8.5, then it is associated with a poor prognosis, and that we should go for avoiding cystourethropy immediately. Even though you give optimal treatment, there can still be 20% of the cases which progress. This will need lifelong monitoring. And they also recommended a neonatal circumcision. And just like that, on the next day, that is on the first day after birth, the creatinine actually went up to 1. And we started sweating a little bit. But we had the micturating cystourethrogram done, and you can see the pictures here on the right. I'll just like to take you through it. All these large scary shadows which you can see here is actually the dilated ureter and the pelvis on the right side, which was showing a significant reflux. As you can see, there's nothing much seen on the other side, which was not having such a bad reflux. The left side was significantly better. And by the MCUG, they had recommended a cystoscopy and the fulguration of the posterior urethral valve, which was confirmed. Parallelly, we also did an MRI in view of the dorsal dermal sinus, and an orthopedic opinion for the CTEV was also taken. On the 4th day postnatally, a cystoscopic fulguration was done of the posterior urethral valve, and the baby had a stormy course post-operatively, but settled down eventually on post-operative day 3. The baby was eventually shifted to direct breastfeeds. It was discharged on a catheter. The parents were really, really intelligent. They actually were taught how to take care of that catheter. And eventually the catheter was taken away 3 days after that. So on post-op day 8, the baby didn't have a catheter either. And a casting was also done on post-op day 10 for the CTEV. So after all that, these are the happy beginnings, I say, because they know a long way ahead with this baby, with a lot of monitoring yet to do. But they were one of the most happiest couples being able to hold this baby. So I would like to bring in some take-home messages. Don't let your knowledge be your weakness. What I mean by that is that most people who see a luto would just say that these do very badly, don't continue the pregnancy. So not all lutos mean terminations. So don't underestimate the power of a common patient. They really have the commitment and the will to go through with all the possible actions that can be done. Less may actually be more, meaning that you don't always need to intervene. You don't always need to put that shunt in. Sometimes just expectant management would also be doing more for your patient. Teamwork makes dreams work. You cannot do this without a great neonatology team, without a great nephrology team, and in our case, even without a great orthopedic team. And of course, there's no one-stop solution for all cases. It doesn't mean that this worked for us, so this is going to work for everyone. So always you will have to customize your treatment, but difficult doesn't mean impossible. It just means you have to work harder. Thank you so much.
Thank you, Dr. Aditi. And I am sure this case will bring up many topics for discussion, and we will wait for that after we finish the other presentations. So with that, I would like to invite upon the stage our third presenter, again another dynamic young gun of Telangana. She is Dr. P. Radhika from Karimnagar. Radhika had this dream of doing fetal medicine, and she went to Ahmedabad and trained herself under Dr. Prashant Acharya there in the ICOG Fellowship Training Program. And then she also visited St. George's Hospital, London, and has been practicing in Karimnagar, again, a very vibrant city. It's actually a smart city of Telangana with a lot of smart and intelligent women there. So Radhika has been providing service to Telangana, Karimnagar and the adjoining districts almost for about, I think, some 6 to 8 years now. And we all are very happy to have her there because she provides grassroots level service at that point, and extremely dynamic in her approach in clinical medicine. It's a joy to have her here, Radhika, and she will be presenting on the white matter that matters. That's the corpus callosum. So the fetal corpus callosum imaging and the problems associated with it. The stage is all yours, Radhika. You can share your slides, please.
Hello, ma'am. Good evening. Thank you for the kind introduction. Hope my slide is visible and my voice is audible.
Not as yet. You need to start sharing your slides, Radhika.
Okay, ma'am. Is it visible, ma'am?
I can see your CV slides, so just move to the next slide.
Yes, ma'am. Am I audible?
Yes.
Yeah, okay, ma'am. Thank you so much for the kind introduction. So as ma'am introduced, today's topic is the white matter that matters, and that is the corpus callosum. As I go through the introduction, a bit of embryology, a case discussion, and ultrasound findings of corpus callosum. This is a beautiful image of God's creation, which shows us the complex interwoven fibers of the axonal commissural fibers traversing through both the hemispheres of the brain. And this is the corpus callosum. The function of corpus callosum is to share the information between the two hemispheres of the brain, the right and the left hemisphere. And studies have shown that severing the corpus callosum has shown some conflicting in exchanging of the information between the two hemispheres. This is derived from a Latin word. Corpus means body and callosum means hard. So as we see, this is in a three-dimensional structure. This is the rostrum, genu, and the body and the splenium of corpus callosum, which is the largest commissure in the brain, along with anterior commissure, posterior commissure, habenullar commissure, the pineal gland commissure, and the hippocampal commissure. All the commissures traverse the information from the right and left brains. A bit of embryology is it happens in 3 steps with commissuration, growth and expansion, and maturation. The interesting thing about the growth and the maturation is that the growth happens in the rostrocaudal junction, that is from the rostrum, the growth starts and extends to the caudal direction from genu, body, and splenium, whereas the maturation happens in the reverse direction and the rostrum is the last to mature. The development is completed within first 4 years of life, and surprisingly, the corpus callosum size is observed to be reduced after 40 years of age. So in the intrauterine age in the development, the corpus callosal sling starts as a glial sling at 11 to 12 weeks of gestation, and the main structure of corpus callosum is completed by 20 weeks. This is important for us to note that the main structure of the corpus callosum is completed by 20 weeks, because before 20 weeks, if we get any doubt of agenesis or dysgenesis or malformation in corpus callosum, we need not jump to the conclusion, and we need to wait till 21 to 22 weeks to confirm about the complete abnormalities of corpus callosum. So 20 weeks is a limit wherein from then onwards, we need to diagnose any abnormalities in the corpus callosum. This is the gross appearance of corpus callosum in an adult brain, and this is the band wherein we see the corpus callosum. In cut section, we see this as a green structure here above the cavum septum pellucidum, and this is a sagittal section. This is the area of our interest in this discussion, which is a typical sagittal view of the fetal brain, showing the falx. So when the whole falx is visible, that is the exact sagittal section. And this gross structure is depicted here as a hypoechoic area, and this is the corpus callosum. The beak-shaped anterior structure, anteromost structure is the rostrum, and this is the genu, body, and the splenium, and these are all different parts of corpus callosum we need to observe. And this is the cavum septum pellucidum seen in the sagittal section. This is the callosal sulcus, which is seen in the third trimester. It is very helpful for us in cases of agenesis of corpus callosum, where we see absent callosal sulcus. And this is the cavum vela interpositae, which are benign. And this is the thalamus. This area is the thalamus beneath the corpus callosum. It is very important for us to measure the length of the corpus callosum accurately to diagnose different conditions in the abnormalities of the corpus callosum. So the anterior most part of the genu to the posterior most part of the splenium is considered the length of the corpus callosum in the mid-sagittal section, where the vermis is completely visualized along with the primary fissure. And along with that, we even need to image the course of pericallosal artery. Coming to my case, this is a 27-year-old second gravida with a previous miscarriage, abortion, and from a non-consanguineous marriage. This time it is a spontaneous conception, and she came to us at 24 weeks of gestation for a targeted anomaly scan. Her past obstetric history was the termination was done at 20 weeks due to corpus callosal agenesis, which is the area of interest in today's discussion. And the POC of that previous pregnancy was sent for chromosomal microarray, and it turned out to have a gain in chromosome 1, which was classified as a variant of unknown significance. Though it was a variant of unknown significance, parental CMA was also suggested. They underwent the parental CMA, and there were no copy number variations, suggesting that this gain was de novo. In the current pregnancy, the quadruple screening showed low risk for trisomy 18, but an intermediate risk for trisomy 21. And a targeted imaging in this pregnancy showed a small corpus callosum for that period of gestation. So that there lies the importance of measuring the corpus callosum accurately from the anterior most part of the genu to the posterior most part of the splenium. And for 24 weeks of gestation, when she came to us, the corpus callosum was 26 millimeters. And when we plotted it against the nomogram, for 26 weeks, it was less than 10th centile for that gestation age. And if you see this short clip, we can see that the posterior bulbous part of the splenium is not clearly seen in this video. As I said, the completion of the corpus callosum is done by 20 weeks of gestation. She was 24 weeks by now. We should have been able to see a clear splenium as well. So we counseled this lady because she already had a history of corpus callosal agenesis in previous pregnancy, and that was terminated. This time they were ready for all the investigations. Amniocentesis was done, sample was sent for QF-PCR, microarray, and whole exome sequencing, and further referred to MRI for a second opinion. Even the MRI also confirmed similar findings with short corpus callosum and thinning and loss of normal bulbous posterior splenium, which diagnosed as a callosal dysgenesis, and along with that, they could see pachygyria. Additional information was the globes, they were widely apart, and they could see hypertelorism as compared to the normal distance between the two orbits. It was hypertelorism, and they could come to a radiological diagnosis of BW syndrome, which is Periaxer-Winter syndrome, and this was only a radiological and ultrasound and MRI diagnosis. Here comes our genetic testing result. Surprisingly, the whole exome sequencing confirmed the same pathogenic variant with the Periaxer-Winter syndrome. And though the microarray was normal, the whole exome sequencing confirmed the condition. So in previous pregnancy also, they had done only microarray, which did not show any significant pathogenic variant. I would like to thank Dr. Madhavi Noori Madam and her team for almost making a near accurate diagnosis with the radiological findings. So these are the features of Periaxer-Winter syndrome, wherein there are distinctive craniofacial features and structural abnormalities in the brain, which carries an autosomal dominant or de novo mutation. And we need to explain the couple about the intellectual disability and developmental abnormalities which are associated with this syndrome. So how to counsel the couple? We told them about these features, and they decided for, unfortunately, for the termination of pregnancy. So whenever we have a confirmed case of agenesis of corpus callosum, we can classify into either isolated or whether it is associated with genetic syndromes, which can only be made out after testing. Isolated is when all the genetic conditions are ruled out and there are no other intracranial structure abnormalities or any other abnormalities in the fetus as such. So if it is isolated, rarely it has a good prognosis. Even then, we can't assure the couple of a real normal newborn after the agenesis of corpus callosum, even it is isolated. So if it is associated, definitely we need to discuss about the cognitive dysfunction and the neurodevelopmental delay in the newborn. So these couple, they went ahead with the termination, and the sample was sent for autopsy, and even autopsy also confirmed corpus callosal dysgenesis. So the other the abnormalities of the corpus callosum is complete agenesis and thick and thin corpus callosums, which are again associated with genetic syndromes. As discussed, the agenesis is 1 in 1,000 incidents, and it is often associated with other extracerebral and cerebellar abnormalities. And there is one direct sign in agenesis of corpus callosum and many multiple indirect signs. And we all suspect agenesis in the axial section, in our routine axial section of the fetal brain. So this is the axial section wherein we do not see the cavum septum pellucidum. The cavum septum pellucidum is absent, and there is a colpocephaly. There is a teardrop-shaped ventricle, and the medial walls of the lateral ventricles are parallel, which goes in favor of suspicion of agenesis of corpus callosum, but the confirmation is only in the mid-sagittal view. As we see, this is a normal corpus callosum, and in this video, we are not able to see hypoechoic corpus callosum. Along with that, the callosal sulcus is also not visualized. Callosal sulcus usually is seen in third trimester. So this is a direct sign of corpus callosal agenesis. Along with that, we have the abnormal course of pericallosal artery. Sometimes it also be associated with the interhemispheric cyst. And this is another paper published telling about the partial agenesis of corpus callosum. They say that it is not only important to see the presence or absence, as we just now discussed, that it is not only the presence or absence, but also the shape of the cavum septum pellucidum that is important. Abnormal length to width ratio has to be taken care of. This is the length of the cavum septum pellucidum, and this is the width of cavum septum pellucidum. This is the length and this is the width. So normally it is more than 1.5, and if the ratio of the length to width is less than 1.5 and the centile is less than 5th centile, we need to suspect partial agenesis of corpus callosum. And here you can see the thick corpus callosum with partial agenesis. And this is a thin corpus callosum. This is a thick corpus callosum. Here you can see more than normal thickness of the corpus callosum. The studies showed that it is of a transient finding and uncertain significance. Telling all this, and I could just say that the human brain is by far the most complex physical object known to us in the entire cosmos. And with the help of all the team and the entire team of Society of Fetal Medicine and our experts, and with the technology, let us try to find out a bit about the fetal brain. And still, I would say the white matter that matters is the corpus callosum. And thank you everyone for your patient listening. Thank you, Society of Fetal Medicine, under the guidance of Dr. Ashok Khurana, sir. Thank you so much for giving our youngsters this opportunity for showcasing our cases. This is a really wonderful platform for all of us. Thank you, Chinmay ma'am. Your energy and expertise is always awesome. Thank you so much, Alok sir, for your extremely valuable inputs and guidance, and you could do wonderful mentorship. Thank you so much, sir. Thank you all.
Thank you, Radhika. And it's a very proud feeling for us, from all of us from SFM Telangana, because the future seems to be very bright for SFM Telangana, with all of you putting in such beautiful presentations and putting in so much effort into understanding the nuances of imaging and putting that into clinical perspective. So stay tuned, because we will have a lot of questions at the end of all the presentations. I think we have to take a short break for the trade partner videos. And after that, we have 2 more exciting presentations coming up. And I would request all of you to just stay tuned and till we come back after the trade partner videos. So welcome back, everyone. And I'm sure now we are all refreshed to get on to the next 2 presentations. Again, very intriguing presentations awaiting us. So I will invite on stage Dr. Pranhita Reddy. Dr. Pranhita is another young gun from Telangana who is now running her own center in Hyderabad. And she trained with us earlier and then worked in her center is called Vivera. Vivera is a very nice name for the fetal medicine services that she provides in a region called Kukatpalli in Hyderabad. And she will be presenting one of the cases that she has seen, diagnosed, and understood as first trimester holoprosencephaly. All yours, Pranita.
Thank you, Madam. Good evening, everyone. Firstly, I would like to thank SFM and all the seniors for providing such a great platform for all our young presenters to present our cases. So I'll directly go into my case for today. It's first trimester holoprosencephaly, and I will start with my case. So we had a 27-year-old primigravida at around 11 weeks who had come in for a routine NT scan. She was not consanguineously married with a spontaneous conception, and there was no known medical or surgical history or any significant family history. So we went about to do a routine scan, and to break the monotony, this is what we saw in the axial section of the fetal brain. So there is something missing here, which is very eminent. There is an absence of the butterfly sign, which we regularly see in our normal NT scans. So what we can see here is there is a single monoventricle, absence of the falx, and the choroid plexus seem to be meeting at the midline. We went on a bit caudally, and in the transthalamic view, we see that the same, there is a monoventricle, absence of the falx. The thalamus seemed uncleaved. In contrast with the normal image, you can see that the thalamus is separate by the interthalamic fissure. So with this, we had come to the diagnosis of holoprosencephaly, and in specific, lobar holoprosencephaly. So once we see holoprosencephaly, it is a must to look into the facial features. So going into the facial features, in the transorbital planes, you can see that the orbits are tiny and closely placed. Also, in the sagittal view, strikingly, you see that there is an increased nuchal translucency. And if you look closer, the forehead seems flattened. There's a flat nose, and there is also midfacial hypoplasia. Looking into the baby, there was constant tachycardia, and if you look more closely, there was also polydactyly. So we had come to a conclusion, a diagnosis of lobar holoprosencephaly with increased nuchal translucency and polydactyly. Now, briefly on holoprosencephaly, holoprosencephaly is a failure of the separation of the brain into two hemispheres. At the time of NT scan, it is seen in and around 1 in 1,300 pregnancies. So to understand it better, we'll just go through a bit of embryology. First, in the normal brain development, the rostral end of the neural tube forms the prosencephalon. Now, this prosencephalon goes on to form the cerebral hemispheres and the lateral ventricles. At around the 5th week, there is cleavage of this prosencephalon into two cerebral hemispheres and lateral ventricles. Now, in holoprosencephaly, there is a failure of this midline cleavage. And depending on the timing and the degree of failure of this cleavage, we get a spectrum of disorders of holoprosencephaly. Now, in this spectrum, we've put them in descending order from most severe to least severe form. And this is a normal brain. So to better understand, the orange is the ventricular system and the white is the cerebrum. So you can see in lobar holoprosencephaly, which is the most severe form, there is complete loss of cleavage of the cleavage, and because of that, there is a monoventricle and complete absence of midline structures. There is no interhemispheric fissure, and also corpus callosum. In semilobar type, there is partial cleavage in the occipital region, because of which there is a division of the cerebrum at the occipital lobes, and there is formation of the posterior horns of the ventricles. In lobar type, which is a relatively less severe version, in which the cleavage extends from the occipital and also into the parietal regions, but the anterior lobes seem to be communicating, and the anterior horns are communicating. Also, we have a variant, which is the middle interhemispheric variant, in which the posterior, the parietal, and the frontal structures don't seem to separate at the midline, whereas there are divided in the polar regions. So after seeing the spectrum of disorders, the associations, as we have discussed earlier, in around 80% of cases, there are midfacial defects associated with holoprosencephaly. This happens because the forebrain and the face have developed together in the embryonic stage. In the eye, it is associated with hypotaylorism and cyclopia, as you can see in the image. And in the nose, there is depressed nasal ridge, absent nose and proboscis, and it can be cleft lip and cleft. Apart from the craniofacial, apart from the craniofacial anomalies, there is we should also look for extracranial anomalies such as cardiac defects, emphalocele, polydactyly, and renal defects. Because the presence of such anomalies points more towards a chromosomal or a genetic syndrome. So in holoprosencephaly, more than 50% of times it is associated with a chromosomal defect and mainly trisomy 13. Apart from chromosomal defects, there is also a 20% genetic association. Now, this genetic association could be non-syndromic or syndromic. In non-syndromic, we usually have an isolated feature of holoprosencephaly, and this happens because of mutations in the genes involving the normal forebrain development. Usually the sonic hedgehog signaling pathway, which is involved in the midline structure development of the forebrain. And then we have different syndromes which are associated, such as Smith-Lemel-Opitz syndrome, Pallister-Hall syndrome, and velo-cardiofacial syndromes. This is also seen in women with maternal diabetes, showing about a 200-fold increase in chance for a diabetic woman. And also it's associated with teratogens such as alcohol, lithium, retinoic acid, and certain anti-cancer drugs. So once the diagnosis is made based on what type of holoprosencephaly it is, we must sensitively counsel the couple. If it is a lobar or semi-lobar variant, it usually has it is lethal with either in the antenatal period or within the first year of life. Lobar variant, though is relatively is a less severe form, still has a severe neurodevelopmental delay and visual impairment. So that should be explained to the patients. Because of its strong chromosomal association, karyotyping must be offered to these couples, and also because of the genetic association, if the karyotype is normal, a whole exome sequencing could be offered after it. Now, the next question after counseling the couple would be the chance of recurrence, and the question would be about the chance of recurrence and the plan and the next pregnancy. Now, all this depends upon the etiology of the condition. If it is associated with chromosomal trisomies, then the chance of recurrence is about 1%. If it is if it is a genetic syndrome, then based on what genetic syndrome, it could be 25 or 50%. And if both the chromosomal and genetic reports come normal, then these isolated cases still have a 6% chance of recurrence. So back to our case. After making the diagnosis, we did counsel the couple sensitively, and we had told them about the guarded prognosis associated with it. We explained them the chromosomal and genetic association, and the option of chromosome testing was given to them with DNA storage for sequential genetic testing if required. So the couple opted for termination of pregnancy, and the products were sent for chromosomal testing. So the CMA reported trisomy 13 in this case. So parents had come for post-test counseling. Since it was a CMA, we had offered them a couple karyotype, and it came to be normal. And then we could confidently counsel the patients that the etiology was most likely a de novo mutation, and the chance of recurrence in the next pregnancy was approximately 1%. And she could go for a routine pregnancy scans, the early pregnancy scan and the NT scan. And if the NT scan was normal, then she was given an option to consider NIPS for chromosomal screening in the next pregnancy. So with this case, the take-home message which I would like to give is first trimester ultrasound is critical for the detection of holoprosencephaly, especially because of its lethal condition. It allows timely counseling and management of the couple. Lobar holoprosencephaly shows absent FARCs, uncleaved thalamus, and a monoventricle. And when holoprosencephaly is seen, always look for craniofacial anomalies, as these may point towards chromosomal abnormalities or any genetic syndromes. And because of its strong association to chromosomal aneuploidies, karyotyping should be offered. And because of its association to genetic conditions, if the karyotype is normal, a whole exome sequencing can be offered. Thank you, everyone, for the patient listening.
Thank you, Pranita. I mean, holoprosencephaly is not a very difficult diagnosis to make, but like you have presented, it is not very easy to counsel the patients, and one should not just stop the moment they see holoprosencephaly. Okay, this is holoprosencephaly, nothing else beyond it, because there is still a lot of understanding about the pathology, and also more importantly, how you prognosticate the whole thing and counsel post diagnosis regarding the occurrence of this condition in future and how to prevent recurrence if possible. So thank you very much, Pranita. Stay tuned because, like I said, there'll be a lot of questions to answer after we finish all the presentations. With that, we come to the final presentation. And last but not the least, we have the youngest gun here because she's still in training. Dr. Ankita is a fellow in fetal medicine, and during her fellowship, she is taking care of some cases and working out genetic reports. And in that process, she has discovered some genetic pearls in cases with recurrent pregnancy losses. So Dr. Ankita will make a short presentation on genetic lessons in RPL. Ankita, we can't hear you. Hello?
Am I audible now, ma'am?
Yes, yes.
Okay. Good evening, everyone. So I'll be talking today on genetic lessons in recurrent pregnancy loss. So a pregnancy loss or a miscarriage, it is defined as spontaneous demise of pregnancy before fetus reaches viability. It is a significant negative life event, and its repetitive nature may intensify the grief experienced by couples.
Click on the slide and then move here.
So according to ESHRE, recurrent pregnancy loss is defined as loss of 2 or more pregnancies, whereas ASRM defines it as a loss of 2 or more first trimester clinical pregnancies, which are either documented by ultrasonography or by histopathological examination. Recurrent miscarriage is defined as 3 or more first trimester miscarriages. So there are different etiologies for recurrent pregnancy loss, and today I would be concentrating on genetic and chromosomal abnormalities. In about 50% cases of RPL, there is no clearly defined etiologies, but among known etiologies, the most common ones are chromosomal and genetic abnormalities, which can be present either in the product of conception of fetus or parents. Among fetuses, the most commonly seen ones are aneuploidies, whereas in couples, balanced translocations are more commonly seen, contributing and seen in 2 to 4% of couples with recurrent pregnancy loss. And also this incidence increases with increase in number of miscarriages, high up to 5.7% after 3 miscarriages. The risk of miscarriage also depends on type of parental chromosome rearrangement, with miscarriage rate of 54% with reciprocal translocation, 49% with chromosomal inversion, and 34% with Robertsonian translocation. Balanced structure chromosome abnormality is rearrangement of genetic material either within the same chromosome, which is inversion, or between 2 chromosomes like translocation, with no overall net gain or loss. And also in a study done by Franson et al., where they have compared 2 groups, one where either of the couple were carrier for balanced chromosomal translocation with normal group, where they have seen that the overall cumulative live birth rate was comparable between 2 groups, which was around 83%, but the risk of subsequent miscarriage was higher in carrier couple group. So with this introduction, I would like to proceed with a case discussion. Here is a lady, 29-year-old, non-consanguineously married for 5 years with history of 4 miscarriages. First one was a missed miscarriage at 9 weeks where CRL was documented. Second one was a missed miscarriage at 5 weeks. Third, she had a blighted ovum followed by spontaneous complete miscarriage. And at last, again, she had a missed miscarriage at 7 weeks where she had underwent surgical evacuation of retained products of conception, followed by products of conception were sent for microarray. So, which test is indicated on product of conception and when is a dilemma which we'll be having. So, RCOG recommends that product of conception should be tested with third and subsequent miscarriage or in any second trimester miscarriage. And with different kinds of tests available, karyotyping has risk of culture failure, whereas fish looks only at specific chromosomes. Hence, microarray is a better and currently preferred test, and it also overcomes the limitations associated with karyotyping and fish. So coming back to our case where microarray was done on product of conception, the report revealed gain on chromosome 11 on loss on chromosome 13, leading to trisomy of chromosome 11 and monosomy of chromosome 13. So what to do next? So apart from routine investigations which are done in recurrent pregnancy loss, there are specific investigations which has to be decided based on specific case history. So is parental karyotyping indicated in all cases? So RCOG recommends parental karyotyping if product of conception has showed any unbalanced chromosomal translocation, or when the tissue is unavailable for testing, or the test has run but that was unsuccessful on product of conception. And doing a parental karyotype was very much important in this scenario to know the recurrence of this abnormality. If parents are carriers, then there are chances that this abnormality may reoccur in future pregnancy. So we have advised a couple karyotyping where karyotype report of wife was normal, but karyotype report of husband showed a balanced translocation between chromosome 11 and chromosome 13. So what to do next? Genetic counseling plays a very important role whenever a structure or genetic factor is identified in cases of recurrent pregnancy loss. And also outcome depends on chromosomes involved and type of rearrangement. So whenever a couple are carrier for balanced chromosomal translocation, the product of conception forming has following possibilities. So the fetus may have normal karyotype or same balanced structure chromosome abnormality like that of one of parent, or it may have an unbalanced structure chromosome abnormality which can lead to miscarriage, stillbirth, or child with major congenital malformations. So as we can see here, when a person with balanced translocation participates in meiosis due to inadequate segregation during meiosis, unequal distribution of genetic material may happen, leading to gametes with either duplication or deletion. And with such gametes fuses with normal gamete, the resultant product of conception has unbalanced translocation. So it was seen that 33 to 39% of miscarriages were associated with unbalanced translocation in couples who were carried for balanced translocation and with recurrent pregnancy loss. And this understanding of this risk is very much important for the couples to take an informed further reproductive decisions. We should also counsel regarding treatment options of pre-implantation genetic testing for any specific translocations identified and transfer of unaffected embryo or use of donor gametes. Though there are very limited studies done which have showed the advantage of this treatment over natural conception and conservative management. So my take-home messages are couples with recurrent pregnancy loss and abnormal genetic results should be referred for genetic counseling and treatment options to support in their informed decision making. The psychosocial needs should be taken into account while offering and organizing care for such couples. And peripheral blood karyotyping is the test of choice for couples where pregnancy tissue has showed an unbalanced translocation, or if tissue was unavailable for testing or testing was unsuccessful. So these are my references. Thank you. I would like to thank Society of Fetal Medicine for this platform. Thank you so much, Chinmay ma'am, for this opportunity. And thank you, Alok sir, for your guidance all through. Thank you.
Thank you very much, Ankita. And I think that was a very nice summary of how genetic testing is done in cases of recurrent pregnancy loss, and a very important message that why karyotype should be done in couples and why CMA should be done in product of conception, because that is something which is really poorly understood, and very often we have people advising the wrong tests and getting the inappropriate results. So lots of applause all of you are getting from the audience, and I really have to thank the audience for 303 people to be online at 9:30 p.m. And it takes a certain degree of madness to be in this drive, and Society of Fetal Medicine has brought together like-minded people. So I feel the people with similar mental disorders have come together. And so we are all here and we are enjoying we are enjoying the mental stress of each other, but this is really nice to come together. So I'll now hand over to the master of the ceremony, the master of the webinar, the master of this concept, Dr. Alok Varshney, to take on the discussion from here forward.
Dr. Chinmay, we are not going to let you off so easy because there are so many questions and you also
Yes.
need to answer a few of them at least, or at least rally your young brigade behind you to answer these questions, which are there.
Questions.
So there are
Yes,
not very
absolutely.
many. First, let's ask Khurana sir what he thinks of today's performance by the young guns. He's there. We would like to hear him.
Well, a very good evening to everyone. And I'm always dumbstruck and awestruck and superstruck when I see how far we have reached in our part of the world in fetal medicine. We have the youngest in our groups now speaking like experts, understanding like experts, and practicing like experts. And I'm so glad we all have a forum where we can communicate with each other at such an excellent level. I mean, you take a program like Young Guns to anywhere in the world, and they'll think that they're the world's most experienced experts and talking like this. And congratulations to you, Alok, for putting all this together. It's really amazing. And congratulations to each of the participants today for keeping up these grand world standards, which I would have never believed could possibly have existed 15 years ago. And Chinmay, you and me have been in this together for many, many years, and you understand where we have reached today from where we were 15 years ago. It's completely amazing, and congratulations to all of us for having achieved this.
Absolutely, sir. Absolutely. And I think, I mean, we have stood on the shoulders of giants. So I have nothing to say there. And the credit goes to you, sir, for kind of lighting that first spark. And the way Dr. Alok has taken up this project is really inspiring. I was watching with pleasure what he was doing with the youngsters. So, Dr. Alok, carry on.
Yeah, thank you. Thank you, sir, for your words of wisdom and appreciation for the young guns. I think they are going to cherish them forever. So we do have a few questions in the chat box. So I want the young guns to unmute themselves and handle those questions. So the first question is epiphyseal stippling in the third trimester pathological? I
Dr.
think
Shushma, Dr.
Yes,
Shushma, can you take that?
Yes, ma'am. So epiphyseal stippling, actually, the word we use it only for postnatal X-rays. For prenatal ultrasound, it is not actually stippling that we see it as, but we see it as ossification centers which have appeared prematurely. So depends on which epiphysis has appeared, because proximal femoral epiphysis appears after birth, whereas distal femoral epiphysis appears in the third trimester only.
So in nutshell, in the third trimester, if you see distal epiphysis and the proximal epiphysis in the around the knee joint, it need not be pathological. But if it is appearing in the second trimester, then of course it is going to be pathological. So another question which there in the chat box is, in the second child, is there associated microcephaly?
No, sir. Child is doing fine.
Yeah, child is doing fine. So
I have a video clip also if I can share it.
It's okay. We believe you.
What is the
So,
clinical significance of the vertebral clefts?
Actually, in CDP, ossification is deranged. So these vertebral clefts will fill up postnatally. They fill up and it becomes normal mostly.
yeah, so basically it is delayed
Hmm.
ossification. So they can be associated with genetic abnormalities, but majority of the times they fill up.
There's one more question. What is the significance of premature ossification of calcification at 17 weeks in the absence of flat facies and epiphyseal stippling?
Calcaneal ossification histologically it starts from 13 to 17 weeks. So I think this should be okay.
If you don't see any other signs of chondrodysplasia,
Yes.
are you worried if you see a calcaneum ossified?
No, ma'am. We'll just review them at anomaly scan time.
So you will report it and leave it as such hanging, and then the patient will go and have one more scan and one more scan and one more
I
scan.
don't think it requires reporting, madam. 17 weeks is normal histological calcification happens.
We'll take Dr.
Please.
Khurana's opinion
Yes,
on this. So,
ma'am.
sir, if we see something like that, should we report? Should we not report?
I always believe in reporting everything that I see, but I also believe in writing an explanation for it within the report. And I always do it in a duplication, which means in the body of my report, I will comment on it. And in the conclusion of my report, I will also comment on it, even if it is a copy paste. Because there are lots of us who will only read the conclusions and will never read the body of the report. And there would be some vice versa who would want to read only the body and forget about reading the conclusion. So we cater to both of them. The idea is to not let communication remain half-hearted.
Absolutely, sir. Thank you for that. Because, like Shushma, you were saying that this is really not so significant, so maybe not reported. That's what we generally tend to think. But this advice which sir is giving is coming from a wealth of experience over the many decades. I'll say, sir, now, sir, because you cannot fake that you've been working for many decades now, almost half a century.
Half a century this year.
Half a century.
Yeah.
Yes, sir. So that's why the point is that you better report what you're seeing, but also cover it by an explanation of whether it is significant or not significant, and does it warrant any further testing, just like we do for the EIF. So it's a good idea to report it, but complete the whole sentence. So any genetic counseling done for the recurrence, and what is the current status of the second baby who had features of CDP? Is the mental state normal? So all this go to you, Sushma. Answer them all together.
Yes, ma'am. Mental state is normal. The boy is doing fine and attained all the milestones. And the height is also good.
Did you do any genetic counseling for the recurrence?
We have advised them, madam. We have advised them. Now that they have come for the third delivery, they were with us for a few days and we have taken the opportunity to advise them genetic counseling.
Actually, first time they have done the whole exome sequencing in the first pregnancy, and that has turned out to be normal. So maybe that is why the parents are reluctant to spend another huge chunk of money for evaluation in the second trimester, second baby.
And this gives a lot of satisfaction to them when the first child is otherwise normal. Correct. They feel, okay, fine. We know this phenotype. And in fact, if you do genetic counseling, they have the risk of getting confused because an experienced geneticist will say, how do we know that this is not another phenotype of another genetic condition? So technology and knowledge comes with its own pitfalls. But I think so. Sushma, a lot of good wishes to you. Beautiful presentation. And this is a very special wish for you coming from your own teacher who's so proud of you. And that's really good. So we all clap for you. And that's wonderful.
Thanks a lot, ma'am. Thank you, sir.
Yeah. So everybody has given you excellent remarks and that you should be very proud of. And then we come to the next presentation.
There's one more, one more question by Dr. Dhaval Patel. And he asked how to see and at what gestational age we can see short phalanges. Because in the case with Sushma presented, the baby had brachytelephalangia.
So we look for it only when we suspect CDP in anomaly scan. When there are other features, then we move on to look for brachytelephalangia. There is no paper that says what is the actual nomogram, but we compare it with the middle phalanx.
Correct.
And see if it is different.
Yeah, so not only I mean, CDP, actually, sometimes the brachytelyphalangia, it's a autosomal dominant condition. So check the parents' hands. One of the parents might be having short distal tip of the phalanges. And sometimes this can be, like in one of my cases, he was married to a woman who also had flat face. The guy had brachytelyphalangia and the woman had flat face. So the child had both the problems. So this is also possible. So let's move on to the next question.
So the next one was by Dr. Radhika. I think this is directed to Aditi, and that says, "What was the fetus sedated for the procedure?"
No, the fetus wasn't sedated for the procedure. We just chose a time of quiescence.
So everybody has appreciated your presentation, Aditi, and given you a lot of credit for the messages that you gave at the end.
Thank you.
So amniocentesis and vesicocentesis, can they be done at the same sitting?
They can be done at the same sitting. However, in our case, we had plenty of time. We had the patient come in to us at 16, almost 17 weeks. And we weren't, I mean, though they were committed towards the amniocentesis, we weren't sure whether they would stay committed if the luto progressed severely. So we thought we'd take it step by step. First, if there was a genetic issue, then maybe they would have reconsidered the entire situation. And that's why we went for a stepwise approach.
So when should we consider vesicocentesis in a case of luto?
So like I showed, there was a paper which says that at least one vesicocentesis can be offered that can help you both ways. One, in counseling the patients, because if you get bad biochemistry, then probably you could explain to them how the baby wouldn't do well enough. And then again, of course, if you are looking towards the shunting, then a vesico pre-shunting would help you decide the prognosis.
So here I would like to extend the question to Khurana sir or Dr. Alok, because there are some concepts that just one vesicocentesis is not enough, because the first sample that you are taking is actually a sample of urine that's been there for a long time. And you probably need to repeat the vesicocentesis to take a decision regarding shunting. So what is your opinion there?
Yeah, so we used to actually use the only test that was available was specific gravity of urine. And we understand that the accumulated urine the first time was never enough. And traditionally, therefore, we used to always do a second procedure 72 hours later and analyze that urine. Currently, of course, we have a few other analytes. If those are available, we can do it in the same process. But most people are not used to using these analytes, and most labs don't make them available. And they're all tongue twisters. I don't even try to remember their names. But the fact is that even today, depending on the degree of obstruction that you see, it's wiser not to use the old urine. I mean, we always analyze it with specific gravity, but I always repeat it 72 hours later. And that would give us a much better idea on how much salvageable is that kidney. So the first one can be a mixed sample, unreliable. The second sample would give us a true function of kidney function and whether the obstruction is salvageable or not, because we now do have two pediatric surgeons coming up who do very good fetal surgery. So if they are going to be able to help us handle this, why not be able to prepare the patient for them at the right time?
In fact, when we were working up for this case, there was one paper very interestingly which we read where this is a paper from Poland, I think, where she used an angioplasty balloon.
Yes.
And inflated it in a needle guided procedure.
Yeah.
So, but I could not get in touch with the authors or get any details further beyond that. But that sounded very promising because it would obviate the need for fetoscopy or anything, where you could direct the needle towards the valves and push in the angioplastic catheter there and inflate the balloon in that place. They had done about 10 cases with almost 100% success rate that they mentioned.
From a relief of obstructive features point of view, not
Yes, sir.
necessarily from improving the outcome. So,
No. And that's why it never, like, this was just 10 cases and there was no follow-up thereafter.
yes,
And we didn't have enough evidence to look for that as such.
yes.
But usually in luto, like Aditi presented, most of the time the patients are not keen on continuing when they know that it's a lifelong follow-up. And This
Yeah.
was one patient who was all out. They
Correct.
wanted everything done. So
Yeah. In fact, this was the reason why the Pluto trial was cancelled, because they couldn't recruit enough people for that trial.
yes, sir.
And they decided they'll never be able to finish the trial. So why should we keep people holding on to hope where there was no hope? And it's only the odd desperate ones like she presented who would really go all the way.
Absolutely. Thank you, sir. So I think the next next question goes to Radhika. So which nomogram for corpus callosum did you use? And do you also measure the thickness in cases of short corpus callosum?
So we do have a few nomograms, ma'am, for corpus callosum. The one which we usually commonly use is the Signini et al. Nomogram. And the second question was measuring of thickness of corpus callosum.
In cases of
Yeah,
short corpus.
in every case of suspicion, we do measure both the length and the thickness. And generally in the short, when the distance, the length is reduced, it's not about the thickness. It is about the length of the corpus callosum, because as we discussed, the growth, it starts from the rostrum and ends at the caudal. So in the caudal area, when the growth is not seen, that we can diagnose it as dysgenesis of corpus callosum. More
When
than
you do
the
when you do thickness, you do thickness of each part?
body, ma'am, body. It is the body we measure for thickness.
But we do have
Because they-
nomograms for.
Yeah, because there are some
Genuine.
papers where you can measure each part. You can do a lot actually. But so should we measure in every case?
See, by doing continuously, we can have an eyeball opinion about whether it is really small, or like we can make out if it is abnormal. In this case, especially because she had a previous termination for callosal, corpus callosal agenesis, we had to measure. But otherwise, every case we have to look for corpus callosum. There is no excuse.
Looking is fine. Should we measure in every case?
If we suspect, we have to measure. Otherwise, we can
Only
just
if we suspect. So basically, that's what Professor Malinger also says. I mean, don't unnecessarily measure, because sometimes unnecessarily measuring will make things difficult. If everything else is looking okay, then eyeballing is fine. Any comments, Dr. Alok or Dr. Khurana?
Sir, Malinger is Malinger. He can look at the corpus callosum and say that it is normal. But for us human beings, we have to start by measuring corpus callosum, at least in the beginning of our careers, so that we get to know that at this gestational age, it has to appear somewhat like that. So this
In
is my
that case, I
opinion.
think it has to be also imperative that every time it is taken in a perfect mid-sagittal and thing, because otherwise sometimes the measurements and the nomograms, the pitfalls are that you may get 13.9, and if 14 is the cutoff, then you have to call it hypoplasia, and then it leads to a lot of. So there is no shortcut to it. If you have to do it in the correct manner. It's like NT, it's like anything else. So
And, including the magnification. When we don't magnify
At
images,
the
make
very
a lot
least,
of mistakes.
it will force you to get a correct section if you want to measure it.
Yeah.
So
Next question.
Mm.
So was the CSP also abnormal in your case, Dr. Radhika?
No, sir. The CSP was normal because, as I had replied, the genu and the body were normal. So the CSP is only restricted till the genu of the corpus callosum, as we see in the axial section. But the splenium doesn't really affect the CSP. The dysgenesis or the.
Yeah, in your case, the abnormality was actually very, very subtle. I really am amazed how could you pick it up, because it was such a subtle abnormality. The length is also borderline. If you see the morphology, it's very, very difficult. So CSP in this case, it was, I think.
Yeah, it was normal, sir. But we intentionally did that. I waited along for the correct section. We did a transvaginal scan, and then we had to make out in view of that previous obstetric history.
This is, I think, a point which Dr. Khurana always does is like, just if you do the 20 plus 2 planes, you miss out on this. So doing at least a basic mid-sagittal should be a plan for, the average fetal medicine doctor here, at least in India. So
another question is thin CSP. How do you manage a thin CSP?
Thin CSP also is, again, we put it in the nomograms, and we can go for a bit of counseling for the taking the previous history. And then, yeah, it definitely needs genetic testing to rule out the possibility of neurodevelopmental delay or cognitive dysfunction, because corpus callosum thickness it is important. Thin corpus callosum
Thin
might have.
CSP. No, not thin corpus callosum, thin CSP.
CSP.
Sorry, I was.
Yeah, if the CSP is thin, you simply do the mid-sagittal section
You
and
do a
see
full
the corpus
nomogram.
callosum.
Yeah, a neurosonogram, yeah.
Okay, I thought it was corpus callosum.
No,
Yeah,
no,
thin
thin.
CSP, we just do a sagittal view and then confirm the corpus callosum, length, width, and everything. And if it is normal, I think, as I told, both thick and thin can be just, you can just tell, mention, as Dr. Ashok Khurana sir just told, we can mention and we can tell the details of that structure and then give the report.
Is there a specific color setting that you have for pericallosal artery?
The PRF settings for neurosonogram, yeah, there is a little, you can just reduce the PRF to some extent, but otherwise it is, because it is an artery, it has a good velocity, it can be seen in the normal
Do you have a separate setting for pericallosal artery, or while you do your TVS,
No.
you kind of get it?
We get it while doing a normal T. We need not change the PRF as such, ma'am.
Anything, Dr. Alok, Dr. Khurana?
So we need to reduce the PRF, you need to increase the gain, and very important that you need to see the angle at which you are insonating the fetus, because if it is coming transversely, you're insonating from the sagittal suture, then you may not sometimes see this pericallosal artery. So important that you scan it from the anterior fontanelle or from the metopic suture, and then you will be able to see the pericallosal artery, because then it will be in line with the ultrasound beam.
So more than the preset on the machine, it's more like the technique with which you approach the artery, when you will be able to get better signals for that. Is that what you're saying?
Yes. So, and nowadays, though, in latest machines, we have slow flow. It has made our job very, very easy. It's just to turn on the slow flow.
Yeah. Also, you see, I do a lot of cheating, and in my transabdominal evaluation of the mid-sag section, I do my flows because they're much easier to handle when you're doing a transabdominal evaluation. With a transvaginal evaluation of flow, you can get a little lost, and the manipulation of the transducer may not be as simple. And when you're stuck in a case, you're not getting your grayscale right, you're not getting your angle right, you're not getting a anatomical section, then you can really get stuck. So I try and do as much of my flows transabdominally because they're technically a lot simpler. Otherwise, in my transvaginal transducer, I often shift downwards I shift out to my cardiac flows definitely, and move into my pulmonary vein flows, which I normally use, and that works very well.
Bimal sir is also with us. Maybe he can throw some light on it.
Nini, I think what you have said is right. The angle is important, and with slow flow, I have a preset made for it. Honestly speaking, both for my transabdominal and transvaginal. But like sir said, transvaginal, it really at times can be, the angle of isolation that you're talking about, it may not be very convenient. And I do follow what sir said. I try to get my flows on transabdominal itself.
Thank you. So let's move on to the next question, I think.
Yeah, I think the next question is now for Pranahita. If whole exome sequencing and CMA were both normal in lobar holoprosencephaly, what next and how would you counsel?
So if they're normal, that means the chromosomes are normal and there's no known genetic condition. You have to look into other associations also. Look at the mother, whether her sugars are controlled, diabetes has its own association, whether she's on any teratogenic drugs, and try to correct that in the next pregnancy. And that apart, in isolated holoprosencephaly, as I mentioned, there is an empiric recurrence rate of about 6% in the next pregnancy, and that should be the couple should be counseled about it. And the next pregnancy scan, since this is very much detectable on scans, even lobar is detectable after 18 weeks, we could go for a routine scan and then look for this in particular.
Sure. So we must at least tell them that there is a chance of sporadic recurrence. And like you very correctly mentioned, if there is any other persistent teratogenic feature, so that also has to be taken into background, because just because we did not find any genetic association, we should not forget the other teratogens like diabetes or your teratogenic drugs. Okay, so which investigations? Okay, now we are moving to Ankita. Which investigation should be offered to the couple with RPL apart from genetic testing?
So, ma'am, apart from genetic testing based on etiology, as we have seen, a basic 3D pelvic ultrasound to rule out congenital uterine malformations, we need to screen for endocrinological abnormalities like thyroid abnormalities with anti-TPO antibodies. And based on history, if she presents with an headache or galactorrhea, we have to screen for prolactin levels. And of course, if there's a history of recurrent VT, venous thromboembolism in family, then screening for inherited thrombophilias becomes mandatory, and screening for acquired thrombophilias like antiphospholipid antibody syndrome also justifies now. So these are the other tests which we can do in cases of recurrent pregnancy loss to rule out other etiologies.
There was another question for you, that why, can you please repeat why karyotyping shouldn't be done in products of conception?
Okay. Karyotyping has its limitation like culture failure because it requires actively dividing cell. And then karyotype, it doesn't recognize submicroscopic like deletions or duplications, which are more common causes for pregnancy losses. So hence CMA would be more justified in doing on product of conception than karyotyping. But then to check for balanced translocations, karyotyping is justified doing in couples who has recurrent pregnancy loss.
How to identify absent splenium of corpus callosum? Can you show the image again?
Radhika.
Radhika?
Yes, ma'am, I'll check. So
while you're putting that image on, what is the significance of absent anterior fontanelle? And how do we go about? I don't think there was a presentation on absent anterior fontanelle, but
I also have no clue about anterior fontanelle.
basically, if you're talking about premature
Craniostenosis.
fusion of sutures, then it has to be a craniosynostosis condition, and then you have to start evaluating for that.
Correct.
So
is my screen visible, ma'am?
Yes, yes.
So this was the as we discussed, this is the most anterior part of the genu, and this is the most posterior part of the splenium actually, but the length should be somewhere around mean is 28 for 24 weeks of gestation, but we got 26. So therein we suspected that the whole length of corpus callosum is not correct. And here also we can't see at 24 weeks, we usually see a bulbous portion like the
like
a little
curve.
bit of bulb kind of thing, like we see in the not our LEDs but the old
Quite
bulbs.
subtle, actually. It's very subtle in your case, but like Dr. Alok said, good pickup.
Actually, if you see carefully, by 22 weeks, it should be reaching up to the tectal plate. But in this case, even at 24 weeks, it is falling way short of the tectal plate. So this is the easy eyeballing method of
and this is somebody who would be doing it routinely would definitely pick up on that, it's not, the border is not getting complete
till
at
here.
the
Yes. And there was a Cavambella interposititis as well. So this is how we can, at least suspect, and then we start measuring.
Yeah, very good.
Yes, ma'am. Thank you.
So, is it justifiable to plan and perform preterm delivery in cases of luto, where ultrasound findings are suggestive of worsening renal function like severe oligo or cortical cyst formation or echogenic renal parenchyma? Dr. Aditi?
I would say no, because it would be counterproductive, I would rather say, because severe oligo, again, we are thinking that the lungs won't be mature enough for that baby. And then you would give an additional preterm delivery, which gives another second punishment for that lung. So definitely no planning a preterm delivery for worsening luto.
So in any congenital anomaly for that matter, where we are looking for postnatal correction, there is really no justification for a preterm birth. So wherever possible, the pregnancy has to be taken to term, because the outcome of surgeries is always important, and that will only be good when you have a good mature baby.
But the
In
same question was asked for ventriculomegaly, ma'am, because once we deliver it a bit early and then reduce fluid by the shunt, then the intracranial structures compression would.
No, for anything, the 37 weeks is a minimum requirement. And beyond 37 weeks also, there is no congenital anomaly where a preterm delivery is going to really help us. So if you speak to the neonatologists or the neurologists, they always insist that it has to be taken to full term, because the risk of prematurity is much more than the advantage of doing anything at that point in time.
Even from an anesthesia point of view, the
Absolutely.
anesthesia does not agree to a surgical process. So then the baby suffers in silence in the nursery. It may as well have suffered the luxury, it may as well taken advantage of the luxury of the intrauterine environment. So premature deliveries are strictly to be avoided when the final answer is going to be a surgical treatment.
Absolutely, sir. So in severe bilateral ventriculomegaly, if we see FOX but don't see CSP and difficult to get mid-sagittal section, how do we confirm CCA genesis? Dr. Alok, I think you need to answer this. And the question is also, why do you then need to confirm CCA genesis?
Correct. So it is going to be tricky anyways, because the CSP and even the septum, it perforates most of the times. And the corpus callosum, if at all, if it is there, it is elevated, it is stretched, it is thinned out. So it is going to be tricky. One thing you can do is you can turn on the Doppler and trace the pericallosal artery route. And if it is coming to be okay, then we can say that, okay, there is a high chance that the corpus callosum is there. But ultimately, it does not make much difference.
Exactly. You have to always look at the bigger picture. There's severe ventriculomegaly.
Correct.
So you know that your prognosis is not really going to change
related.
from like 10 to 90. It's going to change from 91.7 to 92.8. So it's really not worth your time. And also, all of you are busy fetal medicine practitioners. You don't have that only one case to see and elaborate for the whole day. So think about it holistically. Just like there is another question here, in obese patient with fetus in breech presentation, how to do neurosonogram? Pray to God that the baby turns around.
You call the patient back again after some
Yeah,
time.
when it's an, or Kurana sir will tell you shake the baby, but it's an obese patient again. So you do what you can, and when you cannot do it, there has to be a reason that you can't do it, and nobody is going to. So in case of Luto, can we write PUV as confirmatory diagnosis if there's a keyhole sign? Is there a need to do that? I mean, there is a lower urinary tract obstruction, which may be PUV, which may be VUR, which may be anything. I don't think there is a necessary mention to make of PUV per se. You can make it as a differential. What do you think, Dr. Alok?
Plus, again, there's a PCPNDT implication as well. So I think it's best to leave it at Luto.
Leave it as a differential, yeah.
Yes.
Any role of torch testing in recurrent pregnancy loss? So, wow, this is one question which has to come every time, and I'm going to take the honor of answering this question once and for all. So, torch is a test which is done on the mother to see if she has any evidence of recent infection or any evidence of immunity to certain infections. So in recurrent pregnancy loss, there is a pathology which is causing a problem again and again and again. So Ankita told us one problem, that was the chromosomes are balanced but they are rearranged. So whenever they form gametes, they may be unbalanced, and therefore again and again they may miscarry. There can be thrombophilia, again and again they may miscarry. There may be endocrine abnormalities again and again, they can miscarry. There may be uterine abnormalities, and that can happen. So these are recurrent causes. Infections are not recurrent causes. You will be mighty unfortunate to have toxoplasma in one pregnancy, rubella in another pregnancy, and CMV in another pregnancy to cause recurrent pregnancy losses, in which case torch will not help you because it will be different in each case. So you do not do torch profile in recurrent pregnancy loss. You do torch profile when you see ultrasound signs like ventriculomegaly or echogenic bowel or any other reason you suspect calcification in viscera. You do that to check maternal infection status. There is no role of torch testing in recurrent pregnancy loss.
I think we have reached the end of the questions. No more questions are coming. Mohit sir, are you around?
There are still 201 people with mental disorders logged in.
Yeah.
Amazing, absolutely. I think we're very much on the right track.
Okay. Final words from you, Khurana sir.
Well, the final word is again appreciation. Alok, this has been the most phenomenal, and with the other concept of the big guns and not just the young guns, we have now so much to choose from, and so many forums for our younger colleagues to get a chance to present their work. It's really phenomenal. What I would request everyone to do is to try and put their cases together and to put the research together and try and publish it in our own journal, which is the Journal of Fetal Medicine, so that we can finally use that as a textbook. And then perhaps we will then move on to two different journals, one which is a conventional journal and the other is a journal of case presentations, so that then becomes an ongoing virtual atlas for us. So all of you, if you could please write in, and we'll get going on printing, publishing all of this. And congratulations to everyone. Thank you, Alok, for putting this together. And Chinmay, you're always a shining torch which inspires a lot of people. And I can see that Telangana has come a long way. I'm sure Bimal has a few words to say on how he's handled small town young guns. Thank you for bringing them forward, first of all, Bimal. But congratulations for creating so many young guns.
Sir, you created us, we creating a few more. It's something like Chinmay said in the beginning that we are your creations. So you also took us under your umbrella when we are still young, but then we were younger at that time.
Thank you.
Yes, one thing is there even today, it proves that, say it's not that all the speakers are practicing in very, very different areas, small towns, and with this kind of work that they're doing, this is in the true sense, I think, which you always dreamt about, that it shouldn't be restricted. Fetal medicine, good fetal medicine practice should not be restricted only to the metro cities, but everywhere. So I think we're on the right track, but miles to go before we sleep. India is a huge country, it will still take time. But I think the path is there, so we should achieve it soon, few years down the line.
Absolutely, sir. Thank you so much. And I'm missing Dr. Shagun here. She's actually traveling today. She's our secretary of the Society of Fetal Medicine. And it's been a joy to work together with this entire enthusiastic team. So first of all, I would like to thank the Central Secretariat to give us this opportunity to participate in the Young Guns program. And all the presenters for today, Dr. Shushma, Dr. Aditi, Dr. Radhika, Dr. Pranahita, and Dr. Ankita. So like Khurana sir said, please work more in your presentations. Try to put them together as case reports and continue, looking for more. Don't just start looking for cases when somebody asks you to present. Be ready with your cases and look for that opportunity to present, because SFM gives you lots of opportunities. In every conference, you have free papers, you have abstracts. And sir has given this unique opportunity of presenting the free papers also in the main hall. And that's something which is extraordinarily important for people at that stage, because I also remember those days when we used to present a free paper, and if somebody actually listened to our data, we used to feel so grateful. And here he actually puts it in the main session so that everyone can come and listen and you feel good. So do that. All of you must attend most of the SFM conferences because they're some of the best conferences to attend, actually. The true academics. And thank you, Dr. Alok, for the, commitment and dedication with which you've taken this project forward. It was truly inspiring to see you interact with the youngsters. Bimal sir, Mohit sir, all seniors coming and actually standing here and encouraging the youngsters is really, really something to be humbled for. The Conferences International for your back-end support, always being there on time, reminding us on time, and getting everything done on time. Thank you. And this extraordinary audience. Even now, there are 123 people. Even after we started our thank yous and goodbyes, because usually people leave by that time. But like I said, Dr. Quran has brought together, when he says like-minded people, we have a different definition for like-minded here. So that's wonderful. And with all that, have a wonderful Wednesday tomorrow, because now it's time to pack off and retire for the day so that we have a good rest of the week here. Thank you so much once again.
Thank you.
Thank you, everyone. Thank you.